Okay, so try to keep you awake after lunch. We're going to switch gear a little bit and talk about earlier stage disease and talk about surgical approaches for earlier stage disease. We have half an hour. We have two speakers who are going to give us a global perspective on surgical approaches to earlier or stage 1A disease. We have one speaker from Asia and one speaker from North America. It gives me great pleasure to welcome Dr. Suboi from Japan, who's going to tell us about life after JCOG802.
It's a great honor to have a chance to speak here. First of all, thank you again to our chairman and Dr. John and this organizing committee members for inviting me to this exciting conference. My topic is life after JCOG802 when deciding on the extent of the pulmonary rejection for stage 1A disease. This is my disclosures. Today's presentation is divided into two parts as shown in the slides. First topic is Japanese experience for segmentectomy. We presented the survival data for JCOG802 at AATS 2021. So you can see the trend in the clinical application. This slide shows about two-thirds of the actual lung cancer resection cases in Japan are involved in this project. Sleeve resection, including the main procedure. Lobectomy was performed 66% of the cases. Wedge resection is 19%, and segmentectomy 50%. Incidentally, the 30 days mortality rate was 2.4% for the pneumonectomy, but about 0.3 for the segmentectomy and wedge to the lobectomy. Compared with 2018, we can see that the lobectomy has decreased to 4%, and while wedge and segmentectomy has been increased by the 1.5 and 2.5% respectively. I'd like to think that the result of the JCOG802 study reflects this phenomenon. Let's move on to the next topic, the clinical consideration. What kind of the primary lung cancer should be applied for the segmentectomy? In the JCOG prospective study and the past retrospective study, the indications for the segmentectomy as follows. First, the tumor is in the peripheral of the lung field. GGO region predominant region, or solid tumor less than 2 centimeters and solid predominant. Second, radiologically non-invasive cancer for which sufficient margin cannot be obtained by the wedge resection or wedge resection is impossible. Third, impaired cardiopulmonary function. What do you think on this matter? As you know well, JCOG802 key eligibility criteria as shown here. Single tumors and non-small cell lung cancer suspected, no lymph node dissection, no lymph node metastasis. Frozen section, this diagnosis as lymph node metastasis is not mandatory. Center of the tumor location is outside 1/3. And the JCOG1211 study key eligibility criteria as shown here. Surgical margin is estimated on the preoperative thin section CT to be more than 2 centimeters in tumor diameter. And understanding the eligibility criteria for each study will be required. Attention should be paid to local recurrence and complications. Then, What do we need to avoid this? Accurately identified of the intersegmental plane is essential to achieve the adequate surgical margins. As for the management of the intersegmental margin, consider to the following 2 points. Identification method of the intersegmental plane and dividing technique at the intersegmental plane. Each method has its own advantage and disadvantage. These considerations should be taken into account when choosing a technique. In my opinion, sorry, this is a very busy slide. In my personal view of the segmentectomy, first, by using the ICG, identification the rough intersegmental plane is possible. However, the cut line identified ICG and by inflation-deflation line are often different. Second, complex segmentectomy is sometimes difficult, which stapler alone. Third, easier to estimate surgical margin from the tumor by the inflated resected segment. When in doubt, be prepared to take on the rejection line to be adjusted sub-segment regardless of the segmental plane. Fourth, in case of the invasion cancer, actually identification of the surgical margin and target segment is required. If not, local recurrence and complication may increasing. Fifth, on the other hand, if only the electronic scalpel is used, post-operative pulmonary fistula, especially the fistula of the bronchi, is concerned. Tumor extending certainly, especially sublobar, subsolid lesions, required careful margins. The use of the autostapler may be result in the close margin, so it is recommended that a sufficient surgical margin be kept between the resection line and the surface, sutures. Lastly, I would like to introduce ongoing clinical trials on segmentectomy. Two non-inferiority trials, STRONG and STEP up, they are shown here, evaluating validation of the segmentectomy, which lymph node dissection for invasive stage 1A3 lung cancer in patients who can tolerate lobectomy as present. This is my last slide. Thoracic surgeon need to pursue not only the curative intent, but also the less invasive surgical procedure as possible, and reserve the possibility to more intensive treatment for the upcoming life-threatening disease, such as secondary primary cancer, respiratory disease, or cerebrovascular disease, and so on. We believe that attention to those aspects will be led to the long-term survival benefit for all patients for the early lung cancer disease. Less is more. Thank you for your kind attention.